Rahim. In the name of merciful God, we start our session, the first MEASOPRS webinar session to 2020, and this is due to a lot of push and help from Dr. Mohsen Kashkouli and a lot of people in the MEACO who wanted us to do something. We have worked hard in the last 10 days to prepare for this webinar. 5 guest speakers will join us today so that we speak about the orbit and the thyroid related problems. All our guests are experts in this field, and I welcome them as our guests. Also, I welcome our participants from international area, from the Palestine, from Jordan, from Iran, and from Egypt, and in Europe as well. Welcome for everybody. I hope it will be fruitful and successful webinar. We'll start with Dr. Francesco Leoni. He is the MEASOPRS president. Dr. Leoni will talk about the dilemmas in the management of the thyroid orbitopathy, especially the optic nerve compression. Welcome, Dr. Francesco. The mic is yours.
Thank you very much. Can you hear me?
I can hear you very well.
Can you hear me? Thank you very much. Thank you, Mahmoud. Thank you very much for inviting me. I'm very glad to be here. I'd rather like to be in Amman. I've been already once. You invited me twice, so I hope we'll have another chance in the near future. So now we're just meeting virtually. I'm very happy to be here anyway. So when you're ready. So what I'm going to speak today is about the thyroid optic neuropathy. And what is optic neuropathy, basically? It is something very important because it's a potentially sight-threatening complication that is present in about 5% of patients affected by thyroid-associated orbitopathy. And what it is more important is it may lead to a permanent vision loss without a treatment. This is why it's so important. So we know that usually we treat, it can be treated effectively with steroids, and they can restore the visual function. So I'll try to answer to these 3 questions. Is there room for surgical treatment? Why, now, and when? So the first thing, how easy it is to detect this thyroid optic neuropathy is not that easy, and it may be such a difficult thing that an important study group from Michael Kazim in New York has tried quite recently to define a sort of diagnostic formula for thyroid compressive optic neuropathy. This is quite interesting, but it has its own limits, and it can be used practically only to diagnose bilateral optic neuropathy when one or both orbits may lack the relative afferent pupillary defect. What it is extremely important to know is what determines the thyroid optic neuropathy. This is probably determined by a potentially reversible microvascular ischemic posterior optic neuropathy due to an increased pressure by enlarged muscles at the orbital apex. And surgical decompression is usually necessary for neuropathy that is refractory to medical management, and prompt treatment can result in stabilization and improvement of vision. But it's not only vision that we get with surgery. That probably we could get in most patients with steroids. But what it is extremely important when we do surgery in this patient, that the positive effects include the decrease in intraocular tension, relief of pain, improvement in strabismus. We always say that decompression might cause strabismus, but in some cases it might improve strabismus. And usually results are proportional to the extent of osteotomies. And also positive effects include reduction in the need for long-term steroid treatment. So sometimes we have to think about surgery in this patient. And in all the literature, what is quite strange, there is only one randomized clinical trial comparing surgery and medical decompression as first-line treatment for optic neuropathy. This is quite an interesting study, but there was some criticism in another study, which is a reduced study by two friends of mine, actually, Kostas Greek and Jimmy Udin from Murfitz and collaborators, and they study had high methodological quality, but there was the risk of some bias, and also there were just a reduced number of patients. According to the study, immediate surgery does not result in a better outcome, and therefore steroids post-therapy appears to be the first choice therapy. And this is also recommendation from UGOGO, from the UGOGO group. But let's go to surgery. We all know there are some patients that should be submitted to surgery when they have optic neuropathy. And we all know that medial wall decompression is the most effective approach. And this is clear because if you see the slides, if you see these big muscles at the apex of the orbit, the medial recti, you see that if you decompress the medial wall and the medial floor of the orbit, then you can gain a lot of oxygen to the optic nerve. And recently I started with the swinging eyelid approach. Then we all moved to transcaruncular, or as Jeff Rose says, the retrocaruncular approach. And you can get a very nice approach to the medial wall. You can see it very, very clearly. Then a few papers in the most recent years have pointed out that we can have a very effective decompression even if we decompress the lateral wall. So the lateral wall might be not as effective as the medial wall, but it can be effective to decompress the orbit. And again, we can have a good decompression if we just do a fat decompression, if we are quite generous in removing fat from the orbits. And this is especially true in the orbits with thin muscles, as this, where we have thin muscles and lots of intraconal fat. And there are a few papers since the end of the 80s from Richard Anderson that testify this very clearly. Now, recently, we have moved to the endonasal endoscopic decompression, which is really custom-made, very versatile approach. And with this, you can remove the medial wall up to the sphenoid, and then you can remove the medial floor. But even when you have to do decompressions for optic nerve compression, we can preserve very easily the anterior part of the strut, which is this bony bar that divides the antrum from the medial orbital wall. When we don't do very extensive decompression, we can preserve all the strut to avoid displacement of the globe. But when we want to have it very effective, we just remove the posterior part of the strut, and we can enhance the effect of decompression by removing the lateral wall as well. Also, another important point is that what we do with the endoscopic decompression, we preserve the sling. The sling is the periorbita, and preserving a thin or a thicker band of sling, like in this case, allow the fat to prolapse into the sinuses very well, very effectively, but at the same time, we avoid the medial displacement of the globe, and we reduce the chance of getting a very bad esotropia following decompression. But let's go back to the main topic. So when we have to do surgical treatment to resolve the optic nerve compression in these thyroid patients. Of course, in the active phase of grave orbitopathy, if they don't respond to the medical treatment, we have to wait up to 2 weeks. If in 2 weeks' time there is not a visual improvement, it's time for decompression. But that everybody knows that. Is this the only case? According to my experience, this is not the only case. You see, this is another case like that. The typical face of the lady that had steroids before. She didn't respond to steroids. So in this case, we did a medial wall, bilateral medial wall decompression, a lateral wall decompression, and a muellerectomy on the right side. As Dr. Mahmoud we say, Professor Mahmoud will say later, I agree with simultaneous surgery in these thyroid patients. And it's the same for this lady. Of course, this thyroid optic nerve compression. So she had a bilateral decompression, bilateral inferior rectus recession, and bilateral dermagraft to raise her lower lids. So we allow cosmetic to go together with functional surgery to rehabilitate this patient, and we just leave the left medial rectus recession at the second stage. But let's go to the other types of patients in which we should perform a decompression, even if they didn't try steroids. So when you see a patient that had choroidal folds or subluxation of the globe, then please just go ahead with it. And another reason, when we have a patient like this with disfiguring exophthalmos and optic neuropathy, even if she would respond to steroids, there's no reason not to do a decompression, because she will need a decompression at some stage. And so in this case, we did a blepharotomy together with a decompression at the same time. Also, there are some evidence that ptosis or reduction of papillary aperture is a risk factor for this thyroid optic neuropathy. So it doesn't have to have a ptosis like a paresis due to an apex syndrome. But even when you have a reduced papillary aperture, this is very suspect, very dangerous for patients. So you should go ahead with decompression. And you can do lid surgery at the same time, cosmetic and functional surgery. Also, when you have crowding, you have an evidence of crowding at the CT scan at the apex, then we should go ahead with decompression. And also when we have optic nerve stretching, there is a paper by Jeff Rose who just come out in 2020, and he says, he was my teacher, that when you see optic nerve stretching, it might not be, it doesn't mean that you have optic nerve compression, but he feels that he just assigned your opinion when you have correction that's these two types, optic nerve stretching and orbital crowding at the apex, then I would go ahead. Also, one other very important thing, we should consider decompression in patients that have a superior rectus and levator complex enlargement, because these patients have a very low threshold for early intervention, and they usually have inferior visual defects, like in this case, that can improve very, very well following decompression. This has been described recently by, again, the Kazim group in New York. So it's very important to watch, and you see why, because when you see the sagittal scans, you can see that when you have very big muscle, we are always worried about the inferior rectus muscle, but you can see at the apex that the most important is the superior rectus complex, which is very close to the optic nerve. So this is very important. And also, decompression may still be effective in patients that have a prolonged no light perception, provided that is inferior, not more than 3 months, even if there are some papers that say that complete visual loss may be considered a contraindication for decompression. And you see this lady, she presented to us with a complete visual loss of 2 months duration in the right eye. She had progressive visual loss in the left eye, and you can see these are the visual fields in the left eye. Of course, it was not possible to do visual fields in a blind eye or almost blind eye, and we did an extensive medial wall decompression and simultaneously superior rectus recession in the right eye, inferior rectus recession in the left eye. This is the outcome. The picture is almost 1 year after, and you can see 1 year after surgery, the vision improved in the right eye, improving the left eye. The right eye was blind. And this is the improvement of the visual fields in the left eye. So you can have this sort of results. Why does it happen? There are some animal studies, and what might happen in this sort of patients, almost blind or blindish for a couple of months, that there might be remyelination or regeneration of the microtubules in the axon. So this may happen. So no matter how you do it, you have sometimes to restore the oxygen to the optic nerve. You can do it with a no coronal flap. You can do it with a fat decompression. You can do an extensive lateral wall decompression. You can do a medial approach, retrocaruncular. But I want to tell you that the endoscopic medial wall decompression is really the most versatile and the best approach according to us. And also, you can enhance it with the lateral wall decompression. And remember the sling, not to displace the globe too much. So decompression may be required in the active phase of Graves' orbitopathy in cases that do not respond to medical treatment, but it may be required in all these cases. So disfiguring the exophthalmos and optic neuropathy, patients that have prolonged no light perception, provided that they last 3 months, patients that have a superior rectus levator complex enlargement and inferior visual field defects, and patient with reduced palpebral aperture, even if it's not in the slides, but you saw the picture of that lady. And what we have to remember is that in patients with thyroid eye disease, we can have symptoms of recurrent neuropathy up to 15 years following initial orbital decompression. So we always have to follow up these patients, and we all hope in the new agents. So I think I finished with that, and you have to imagine from a desert Rome now during the lockdown that finished 2 days ago, so the Colosseum and the Model Colosseum. Thank you very much to all for this.